So this is the perfect presentation to follow the last one because this is also on falls. So this was my D&P project also with Aspen University on the development and implementation of an evidence-based protocol to increase nurses' initiation of the technology for virtual patient observation. So I'm going to go over the introduction, the purpose of this study, the background, what my PICO question was, the theoretical framework, a little bit of information about the current evidence-based practice literature, the change model I use, the instrumentation, the project design. We'll go over the sample and some data, the ethical considerations and the data analysis with the results and implications for nursing practice, and how to sustain change and recommendations for future projects related to this. So one of the biggest threats to patient safety in the hospital is the unforeseen patient descent to the floor or other inanimate object or a patient fall. The Centers for Disease Control and Prevention reports that $50 billion is spent annually on medical costs related to non-fatal fall injuries, with falls resulting in bone fractures, lacerations, internal bleeding, and increased healthcare utilization. Not to mention, patients who fall are in the hospital on average for an additional 6 to 12 days. In Florida alone, where this study took place, in 2020, the CDC reported patient falls costing a staggering $1.5 billion annually. Virtual sitter surveillance enabled by artificial technology like virtual bed rails and motion detection devices, discriminating between a change of position and the potential urge to get out of bed, has challenged previous methods to decrease falls. The organization this project took place in recently began using virtual monitors to detect and mitigate patient falls. Despite the widespread availability of this technology, it was not widely used throughout the campus, where myself, the D&P student at the time, was employed. I've since graduated. This project explored whether the addition of an evidence-based nursing protocol increased the initiation of VPO by clinical nurses. This is an important and significant step to improving patient safety and quality care. This project accomplished providing a nursing protocol to guide nursing judgment and care for patients at risk for falls using virtual patient observation, or VPO. So my project question was the PICO question as follows: does the development and implementation of an evidence-based protocol increase nurses' initiation of virtual patient observation? This project utilized the Donabedian framework. This three-step approach employs components of structure, process, and outcomes. Donabedian believed that structure influences process, which in turn affects outcome measures. Together, these form the basis of what is required for an effective suite of measures. By applying the Donabedian model to this project, the three core elements of the model were used as follows. Structure was focused on the care environment, specifically the 3 North unit. The process refers to the evidence-based protocol that was implemented, and thus outcomes refers to the number of virtual patient observation, or VPO, initiated orders placed because of the evidence-based nursing protocol being implemented. For the literature review, I used search terms such as hospitalized patient, fall, one-to-one, and video. Inclusion criteria included full-text articles in the English language, including foundational, current, peer-reviewed literature dealing with evidence-based nursing practice. All locations of settings were inpatient acute care facilities for all 15 studies. Participants in 14 studies were adults over the age of 18 years, with only one study including pediatric patients. Another similarity was that consent among patients was sought out in the majority of studies. Variation occurred in the literature with selection processes for VPO. Some studies used the development of algorithms for inclusion criteria, while others made assignments by specific populations. Still, Others use nursing judgment rather than specific guidelines. Each of the organizations in the articles chosen determine a specific number of patients assigned to the virtual monitor technicians. There was slight variation in terms used for VPO, with the most widely used being video monitoring. Regardless of nomenclature, the intervention of remote virtual observation for patient safety and care to decrease falls was consistent across all studies. Data for all VPO outcomes was measured as a rate for all 15 studies. The fall rate per 1,000 patient days was calculated for all studies, including falls and falls with injury. Of the 15 studies, none saw an increase in falls. 11 studies demonstrated a decrease in falls. The conceptual change model that informed this project was the PDSA, or Plan, Do, Study, Act model. This model serves as an opportunity to test a change that is implemented and prescribed in 4 succinct steps to guide the thinking process. As the process or task is broken down into steps and then evaluated for an outcome, improvement could be made on what was to be accomplished and thus tested again. This model emphasizes the use of small tests of change and nicely justifies the project question by utilizing inquiry, practice, and learning. The instrument used to measure the outcome of interest was the evidence-based protocol. The protocol was based on the organizational VPO policy. The protocol was vetted through the organizational faculty, 4 nurse directors, and the Falls Committee in December of 2022. Feedback was provided from all sources and modifications were made. Shared consensus decision-making was reached from all parties via virtual team meetings by January of 2023. The various steps in the VPO protocol aligned with the VPO policy. The rationale and appropriateness for using the selected measure were that this protocol aptly depicted the policy for placing a specific patient population on VPO. Since reliability refers to the extent that the instrument yields the same results over multiple trials, this protocol demonstrated by review of 4 nurse directors, nursing faculty, and the Fall Committee team members to properly address and depict the current policy in place. The plan began with 2 weeks of data collection. This was through the VPO log the staffing and resource team sent via email every morning on how many orders of VPO were initiated by clinical nurses. The purpose was to get a baseline number for this unit of how many times orders were being placed. This cycle's due phase introduced the project to the unit and reviewed expectations. The nurse scientist had a presence on the unit facilitating the adoption and explanation of the protocol to clinical nurses. They attended unit huddles, staff meetings, unit-based council meetings, and met with clinical nurses one-to-one as they were available during breaks to answer any questions and explain the protocol process further. The protocol was placed at every charting station throughout the unit. Finally, 6 weeks of data collection occurred via the VPO log, again addressing how many orders of VPO were placed pre-intervention, during the intervention phase, a 2-week time span, and then post-intervention, another 2-week time span. The study phase of the model concerned comprehensively analyzing the data for VPO-initiated orders. In the ACT phase of the project, we identified what changes needed to be made prior to rolling out this project to other units, thereby improving upon any clinical or technical workflow issues. To evaluate the intervention of this evidence-based protocol on the number of VPO orders placed, it was essential to demonstrate causality between an intervention and an outcome. This kind of project was quantitative, as numerical data addressed whether an evidence-based nursing protocol resulted in increased VPO orders placed based on a convenient sample of those clinical nurses working on 3 North during the 6-week time span this project occurred. Due to constraints of not expanding this project to include randomization, the kind of project described is the PDSA quality improvement methodology, with a one-group pre-test, post-test design. The data analysis relating to the purpose of this project was performed utilizing descriptive statistics. Data surrounding orders placed for VPO before and after the intervention were obtained. Since two different time points before the intervention and again after the intervention were collected, descriptive statistics was the optimal statistical analysis method. Descriptive statistics are specific methods used to calculate, describe, and summarize data in a logical, meaningful, and efficient way. Fundamental concepts included measures of central tendency, such as mean, median, and mode. This project presented minimal risk concerning exposure to physical or psychological harm. There was no risk to experimental treatment for this project. The probability of magnitude of harm or discomfort during this project was not greater than any ordinarily encountered in daily life. Limitations included maturation between the time of the intervention and the data collection period post-intervention regarding clinical nurses' familiarity with the VPO policy and protocol. Therefore, differences obtained could be attributable to these changes as opposed to the intervention. In addition, testing or the process of measuring may have changed what was being measured. In this case, the number of VPO orders, for example, as the reactive effect occurred when the testing process itself led to a change in behavior, rather than it being a passive record of behavior. Before rolling out the evidence-based protocol, the mean number of VPO-initiated orders was 1.86 per day, with the mode and median being 2 VPO orders initiated daily. Post-implementation, the mean was 0.57 VPO orders per day, and the mean and mode and median were 0 number of orders per day. An interesting observation was that the number of VPO orders increased during the implementation period. The mean from June 13th to June 26th of 2023, when the nurse scientist was active on the unit and providing education and the nursing protocol, resulted in the mean being 2.7 VPO orders placed per day. The mode was 2, 3, and 4, all occurring 3 times during those 14 days, and the median or average number of VPO orders placed during this time was 2 per day. The significant finding of this project was that the development and implementation of an evidence-based protocol did not increase nurses' initiation of VPO. The interpretation of the findings from this project indicates that while the presence of the nurse scientist on the unit may have promulgated the initiation of VPO orders for patients meeting criteria, this did not translate into continued use of this technology for safer patient care. This indicates that the liability may lie within the policy for VPO itself or within the discretion of the clinical nurses on 3 North in leveraging technology to support safer patient care. In this case, the protocol was based on the current policy in place, which had been employed for 8 months. Thus, perhaps the clinical nurses did not feel the need due to familiarity with the VPO policy to consult or need the addition of a nursing protocol to guide practice. Another possibility may be a need for more understanding of what implementation means. Perhaps the clinical nurses believed this project was intended for 2 weeks, culminating in ordering VPO or pushing this for patients meeting criteria for 2 weeks alone, and thus did not prioritize this technology, resulting in a lack of ordering for VPO once the nurse scientist was no longer active on the unit. This could have been a barrier. A third possibility may have been that patients did not meet the criteria for VPO for the 2 weeks after the implementation period. A fourth possibility could be a need for more engagement on the nurse's end and utilizing the full potential of technology and avenues for safer patient care. While this project does not support previous findings showcasing that protocols drive engagement of newer technologies, it provides valuable knowledge for policymakers and interprofessional teams at the organization to determine if the policy should be rewritten and new avenues to continue why VPO is still underutilized. The limitation in the current literature was apparent in that no project or study addressed whether implementing an evidence-based protocol would aid in promulgating VPO-initiated orders for safer patient care. This gap was initially found by the nurse scientist in the literature review, and upon researching the problem of underutilization of VPO at the organization specifically, the unit upon which this project took place began the quest for understanding, hence the birth of this project to uncover reasons for poor utilization of this technology. Nurse leaders should care about this project, and the finding is as sitter costs are still very high, and patient falls and falls with injury are quality and safety issues. Due to the data and evidence that VPO is still underutilized, the VPO policy and additional education should be analyzed and discussed surrounding these unusual findings. These findings mean for nurse leaders that the problem either lies in a fault of the policy, a lack of education, or a lack of knowledge on the part of the clinical nurse who can order VPO for safer patient care. An analysis of areas for future research or projects that the current project could have addressed or that emerged due to the present study may include looking at the cost of VPO versus traditional sitter use. Another aspect to consider may be the cross-analysis of VPO that has been successful on a unit regarding clinical nurses leveraging this technology for safer patient care and patient fall reduction over time. Since the study did not address the throughput of VPO in reducing falls, it would be wise to consider this. It would be meaningful to bring this data to staff, patients, and families through a patient family advisory council to view and provide insightful feedback. This could help to augment or change the policy and protocol. Yet another project could be on the psychological impact of VPO on patient care from different perspectives, including the patient, family, and clinical nursing staff. The project's duration may have been a limitation, thus increasing the entire time of data collection pre- and post-implementation, with a longer project implementation phase as advantageous. Recommendations for future practice, policy, and education include further in-depth work through shared governance to edit and augment the current VPO policy. The buy-in and engagement from the frontline staff were missing from the initial creation of the policy, which may well be demonstrated in the continued lack of VPO use. Future practice, policy changes, and educational rollout always should involve the staff that it is informing. Here is just a slide on how I met different D&P essentials during my program. While this project addressed the problem of patient falls using an evidence-based protocol, it did not prove to increase clinical nurses' ordering of VPO, and this is unfortunate. The outcomes of this project provide much insight into the following next steps in future revisions. While physical and psychological circumstances beyond one's control can result in a patient fall, further work needs to be done to reduce this unintended consequence. The future is ripe to continue addressing patient falls. All healthcare workers, including patients and families alike, must participate and actively reduce falls. As more technology unfolds and lends itself to safer patient care, the urge to take advantage of this opportunity will only increase. Thank you for your time, and if there are any questions, I'd like to open the floor to some Q&A.